Welcome back. Moving on in terms of talking about what I would call specialized appliances, we're going to go to one that actually I don't use very often at all, but in rare occasions it can be very effective, and that is a posterior pivot appliance. A posterior pivot appliance is an appliance that actually has occlusion only on the posterior teeth. There is no anterior contact. Classically, if you looked back into the 1970s and 80s, that appliance would look something like this. It would actually have been cast like a partial denture framework. And if you notice, there's occlusion in the back and an open bite in the front. These appliances were designed very specifically to support bad jaw joints. And so if you had a patient who had had disc displacement with pain in the joint, complete disc displacement, these appliances can be incredibly effective at helping those people feel more comfortable. But
I just got to remember that it's back here.
With them. So when we think about it in terms of the effect of the appliance on muscles, there is no, quote, anterior guidance. So the posterior teeth are in occlusion all of the time. So even if the muscle activity was to go up a little bit because of the fact there's no posterior disclusion ever, if you have really hot, uncomfortable joints, these appliances typically make people feel better. Conceptually, what they do is they support your jaw joint. If we go back to the literature on joint loading, and we realize that when only anterior teeth touch, about 60% of the load of the muscles goes onto the joint. When we have posterior teeth touching, only about 5% of the load of the muscles goes onto the joints. So they're designed really to support bad jaw joints. Okay, there's not going to be any really beneficial muscle effects from them. The risks are really simple. There could be muscle symptoms, although I've seen a lot of people wear these without any muscle symptoms at all. More commonly, the risk is you get a posterior open bite when you take the appliance out. You get intrusion of posterior teeth, you get eruption from the lack of contact in the anterior. The particular one you're looking at, that patient came in to see me. She had been wearing that cast appliance 7 years, 24 hours a day. I'm actually a little shocked that her anterior teeth hadn't erupted into occlusion. But for sure, her posterior teeth had changed. When you take the appliance out, she has a posterior open bite of probably 4 or 5 millimeters, which is roughly corresponds to the thickness of the appliance. Now, the good news is, in her case, I was able to just go in and restore the lower posteriors and build her up into occlusion because her anterior tooth position actually had remained fairly reasonable. But this is a big risk, and to show you the most extreme example I've ever seen, this is a patient whose original dentist had created a posterior pivot because she had jaw pain, and he had told the patient that your front teeth can't touch. If your front teeth touch, you're going to get pain back. So if your front teeth touch, you have to come in and I'll build up the posterior more on the appliance. So over the course of time, anytime her anterior teeth would erupt and finally touch, she would go into his office and he would build the posteriors up. Ultimately, over a prolonged period of time, this is how far they ended up getting built up. Incredibly extreme. And now you're left with, well, what happens? You take that appliance out, and that's the occlusion. And so it's a pretty significant ortho case to try and correct, and that's the big side effect of posterior pivots, is you can get these dramatic changes in tooth position. The reality is you don't need to have the lack of anterior teeth to be able to manage these patients' discomfort. You can use a more traditional full coverage appliance, flat plane, with some light anterior contact and then build in some posterior excursive contacts and accomplish what these appliances do but take away the risk. Now, having told you why I don't like them, let me now share with you when I actually have used them. And so this is a patient that came to see me years ago. She wanted some cosmetic treatment done. We're going to have some ortho done to correct some gingival levels in the anterior, and then we're going to treat her front teeth. And she had tremendous wear in the posterior. The upper right second molar was just redone before I saw her, but she's worn holes through the molars, and yet her premolars have almost no wear on them, and her anterior teeth have almost no wear on them. So this is a patient that when I examined her, she was able to go into a retruded position, a seated condylar position, totally comfortably. But when she did, the only thing she was hitting was those molars. And so my recommendation to her was that, yes, we're going to treat your anterior teeth. We also need to treat all these posteriors that have perforations in them. And my suggestion was we treat her in a retruded position with the condyle fully seated, because otherwise I can't control those posterior interferences. If I do nice, pretty, all ceramic restorations on her molars, but she goes into a retruded position, she's only going to be touching on my all ceramic restorations. And she already shows us that she, in fact, grinds her teeth when she goes in that position. So here was my upper arch restoration immediately after being done. Here was the lower arch restoration, just treating the posterior teeth. Here's her anterior teeth. The condyles are seated. The anterior teeth are in contact. The year is 2003. She's happy with everything. I'm happy with everything. And then over time, slowly but surely, she notices that she starts hitting only on the second molars again. And so she would come in and I would adjust them a little bit to get her back on the rest of her occlusion. And then again, a year or 2, 3 would go by, she'd be back on the molars again. Over a period of years, as she was only contacting on the all ceramic second molars, she fractured them. So here she was in 2013, it's now 10 years post-treatment. And if you look, you will notice that I have switched to metal occlusals on the second molars because I replaced them 3 times. And what's causing this is she has a very slowly progressing degenerative joint problem. And so her condyles are changing slightly, not real rapidly, but changing slightly. And as her condyles change, her mandible drops back and her only occlusion is on the second molars. So by 2013, 10 years later, this is what her anterior occlusion looked like. It's significantly open. And if you take a set of models and you try and hand articulate them, you would notice her models actually, the anterior teeth are very close to touching when you hand articulate them, which tells you, in fact, it's not a tooth position change that's causing this problem, it's a joint change that's causing this problem. So now I'm faced with, okay, how do I get her front teeth to touch again? Because right now she can't make them contact. Do I come in and restore the maxillary posteriors or the mandibular posteriors? I can't equilibrate them. It's way too much to equilibrate. In reality, in these kinds of patients that have either had degenerative joint changes or have lost disc that have resulted in changes in occlusion, I have used posterior pivots very successfully to close the open bite. And so let me show you what that looks like. Here's the anterior teeth again. Here's the appliance. It's a base plate, a 1.5 or 2 millimeter base plate on the maxillary teeth. I want the whole maxilla covered because I don't want the maxillary tooth position to change. I don't want anterior eruption or posterior intrusion. I want the maxillary teeth where they are. And then I build a pad of composite, opening the vertical 2 or 3 millimeters in the front, so that she only touches from first premolar back on both sides. She wears that nighttime only, takes it out during the day, and what we're hoping for is we're going to get some mandibular posterior intrusion, a little mandibular anterior eruption, and we're going to have her keep wearing it until the open bite is closed. And that way I actually don't have to redo any restorations, and in the meantime it's very comfortable for her because it's supporting her joints. And so there's what it looks like from the side. On the left is when she presented to me with the open bite in 2013. On the right is 2016. She closed that open bite by wearing that appliance in about 3 months' time. Now here we are in 2019, and that anterior open bite is still closed. She has the appliance. If she ever starts feeling the front teeth start separating, she wears the appliance again. And so that is one use of a posterior pivot. It's a very specific use where you're trying to control the tooth position. Now, obviously, orthodontics could do the same thing with some mini implants for anchorage, but it is a very useful tool, and I have used them several times to close anterior open bites. And again, where she was in 2013 to 2016, you'll notice the maxillary tooth position didn't change at all from that appliance. Now, this concept can be also used in patients with severe posterior tooth wear. So if we take a look at this particular patient, this is a gastric reflux patient. He has massive erosion on his posterior teeth. They're incredibly short. They're too short for you to be able to restore without opening the vertical. The problem is his anterior teeth haven't worn that much. Yes, they're a little on the short side, but if you look at his premolars, like his second premolars on the left side, if you wanted to try and open his bite so you'd be able to restore those teeth, you'd have to open that about 2 to 3 millimeters in there. And that 3 millimeters of opening is going to make his front teeth have an open bite of at least probably 5 or 6 millimeters. You'd have to give him huge anterior teeth if you were to try to do that. So instead, what's really happened is there's probably been some loss of vertical, but there's been a tremendous amount of posterior eruption. And so this is a patient where, in fact, if you use that same exact appliance I showed you, you could, in fact, create a posterior open bite intentionally, so you now have room to restore those teeth. So same concept. It's instead of trying to close an anterior open bite, you're intentionally trying to create a posterior open bite. And then finally, what is the one posterior pivot that I would tell you is commonly used, but it's used as a temporary posterior pivot? It's an occlusizer. An occlusizer is simply 2 little bags of fluid with a tube connecting them. You can keep it in your office ready to use at any moment for patients that have acute occlusal issues, whether they be muscle or joint. You don't have to make an appliance because of the occlusizer. So when a patient comes in and they told you, I woke up this morning, my bite doesn't fit, or I was on a basketball court and I got hit in the chin with an elbow, my bite doesn't fit, my first line of defense is I give them an occlusizer. You can wear it facing up or you can wear it facing down. And the purpose of it is it gives them posterior occlusion and it makes them feel more comfortable that they can rest on something. It takes some pressure off the joint, which also makes the lateral pterygoid less heated. And so posterior pivots in terms of the occlusizer, pretty commonly used. The other posterior pivots I showed you, they're very, very specific as to when you would use one. So if we really look at a posterior pivot, the primary place you'd use it, other than trying to create a posterior open bite, the primary place you would use it is if you have a patient who you cannot seat the condyles without pain. In patients where you can't seat the condyles without pain, if you want to use a posterior pivot as a very short-term appliance and then construct them a full coverage one that provides a balanced occlusion, that would be preferable. I hope this lesson on posterior pivots makes sense to you. In the next lesson, we're going to move on to the use of full coverage soft appliances, so I'll see you there.